Okay, we will start the prostate cancer part 7. Prostate biopsy general concepts. A core are usually obtained transrectally under local anesthesia using transrectal guided ultrasound guidance. Transperineal biopsies have a lower risk of infection than transrectal biopsies. However, transperineal biopsies are often more painful and require more local anesthesia. In men with an elevated PSA, a 10 to 12 core systemic prostate biopsy has a false negative rate of approximately 20% to 30%. For men without an anus, example after abdominoperineal resection, prostate biopsies can be obtained by the following routes. Might be using the transperineal biopsy using ultrasound, CT, or MRI guidance. Ultrasonic imaging can be performed transabdominal or transperineal. Another way is transgluteal biopsies using the CT or MRI. This is another method known as transgluteal biopsies. Transrectal biopsies. Preparing for transrectal biopsies, bowel preparation, the EAU recommend using povidone iodine rectal preparation in addition to systemic antibiotic prophylactic because it decreases the risk of infection complications. Administering an enema prior to procedures does not reduce the risk of infection. However, it might minimize the chance that the gross stool in the rectum hinder placement of the transrectal probe. Culture-based antibiotic prophylactic. This option strategy involving obtaining a rectal culture so that bacterial sensitivity profiles are available before the biopsy. Prophylaxis is then adjusted as needed to cover organisms that are resistant to recommended prophylaxis regimen. The data are conflicting to whether this reduce the rate of sepsis over empiric antibiotics. Empiric antibiotic prophylactic based on the AUA guideline. Prefer an antibiotic regimen fluoroquinolone alone or combination of aminoglycosides and cephalosporin first, second, or third generation. All is an option that the prefer antibiotic regimens. So fluoroquinolone, it's alone or combination with aminoglycosides is an option, like ciprofloxacin. Alternative antibiotic like aztreonam or considered infectious disease consultation. For oral administration, the antibiotic should usually be taken 2 to 4 hours before the biopsy or the procedures. For intramuscular or intravenous administration, antibiotics should be given within 1 hour of the procedures. If the patient has a high risk of having resistant organism, then consider adding an appropriate additional antibiotic to the prophylaxis regimens or consider performing culture-based antibiotic prophylaxis. A risk factor of being colonized with developing an infection from multi-drug resistance organism antibiotic use within last 6 months, hospitalization within the last 6 months, infections after a previous prostate biopsy, history of prostatitis, history of prostatitis and history of urinary tract infection, recent international travels, and non-colonization with an organism resistance to recommended prophylactic regimen. This is a risk factor for being colonized with developing an infection from multi-drug resistance organism used within the last 6 months. This is a risk factor for being colonized. Taking a greater number of core and injection or injecting local anesthesia does not appear to increase infection rate. Transrectal ultrasound trusts for prostate biopsy. Most prostate cancer are isoechoic. Okay, so it's up to 50%. When the prostate cancer is visualized on transrectal ultrasound, it is usually hypoechoic. It is usually hypoechoic. Rarely the prostate cancer are hyperechoic. So that means this most prostate cancer are isoechoic. When the prostate cancer is visualized on TRUS, it is usually hypoechoic, but it is rarely hyperechoic. Color Doppler and Power Doppler ultrasound can improve biopsy targeting by helping localize area that may contain cancer. TRUS cannot really identify the prostate cancer when a prostate is indicated based on other factors. The biopsy should be performed even if the TRUS is normal. Obtaining all the TRUS targeted biopsy often from area that appears suspicious is ineffective. So obtaining all the TRUS targeted biopsy from area that appears suspicious is ineffective. However, a TRUS or TRUS targeted biopsy may be useful when combined with systemic biopsies. Local anesthetics for prostate biopsy, prostate block. A prostate innervation, that's prostate nerve arise from sympathetic and parasympathetic branch of the inferior hypogastric plexus. So the innervation of prostate from the inferior hypogastric plexus by sympathetic or parasympathetic branches. Their course along the posterolateral, that's the bundle on the bundle nerve or nerve bundles its course in posterolateral neurovascular bundle. I mean, it is in posterolateral aspect of the prostate. Posterolateral prostate from the base toward the apex. That's from the base of the prostate toward the apex. So from superior downward. This is posterolateral. This is the neuroinnervation of the prostate. As you see, in posterolateral from the base, here this is the base, this is seminal vesicles. So posterolateral, proximal end, prostate nerve, and it is branches. Prostate depicted in the coronal plane, that in coronal plane, and this seminal vesicle here. So it lie medially. But the neurovascular bundle is posterolateral to the seminal vesicles. This is the prostate. Some urologists apply lidocaine jelly topical to the anus before the biopsy to help decrease discomfort from the inserting the probe. Prostate block anesthesia, the prostatic nerve, which is our sympathetic and parasympathetic branch from the inferior hypogastric plexus. Prostate block technique on each side near the lateral edge of the prostate. Inject 2 to 5 cc of 1% plain lidocaine between the prostate base and the seminal vesicles. Alternatively, place the needle into the lateral prostate at base, mild, and mid and apex. So this is the biopsy site, the anesthesia site, and inject 1% of plain lidocaines as the needle is withdrawn. These two techniques can be combined. This is injecting local anesthesia for prostate biopsy. This is prostate depicted in the coronal plane here. This is the base, this is the mid, and this is the apex. So lidocaine bolus into the base, then into the mid, and then into the apex. So this is transrectal ultrasound in the lateral sagittal plane. As you see, seminal vesicle, prostate. This is the injecting needle. This is the peripheral zone here, and seminal vesicles. Avoiding painful apical biopsies. The dentate line, also called the pectineal line or anorectal junction, is an anatomic divisions between the anus and the rectum. As you see, this is the dentate line and this is the anal orifice outside. So the dentate line lie as this, or known as pectineal line. It is a line that's in the apex. It's near to the apex of the prostate. Okay, so it's also called pectineal line, or anorectal junction is anatomic division between the anus and the rectum. So this is the rectum and this is the anus, anatomical division here by dentate line. Sival to the dentate line, tissue is innervated by branch of the inferior hypogastric plexus. Prostate branch are anesthetized by prostate block. Below the dentate line, tissue is innervated by branch of the inferior rectal nerve, not anesthetized by prostate block. When obtaining a biopsy near the apex, the needle may pass below the dentate line, causing severe pain. So it is passed below the dentate line, this causing severe pain because this area innervated by rectal nerve, as you see here, inferior rectal nerve. That's below the dentate line. To avoid painful apical biopsy, place the tip of ultrasound posterior to the mid-prostate and position the tip of the biopsy needle just inside the end of the probe. As you see, this is a probe. So painful apical biopsies that pass below the dentate line, and this is a biopsy needle pass directly toward the mid of the prostate to avoid the painful. So to avoid the painful apical biopsies, place the tip of ultrasound posterior to the mid prostate and position the tip of the biopsy needle just inside the end of the probe. Then the angle of the probe so that this tip sweep anterior and toward the prostate apex. This maneuver retracts the dentate line away from the prostate apex and allow the biopsy needle to pass above the dentate line, then fire the biopsy gun, as you see here. So this is the angle, and sweep the probe anterior toward the apex to retract the dentate line away from the prostate, and then gun the needle and take the biopsy. So to fire the biopsy gun and take the biopsy. The dentate line is not well visualized on ultrasound, on transrectal ultrasound. This is all the picture. This figure 1. This is diagram from the dentate line to the seminal vesicles, and this is here the figure 2, the painful apical biopsy when insert the needle to the dentate line, area below the dentate line, innervated by the inferior rectal nerve. And here, this is the position of the probe of the ultrasound toward the prostate, the mid part of the prostate. And here, this is to retract the dentate line inferiorly or below, angle and sweep probe the anterior toward the apex of the prostate to retract the dentate line away from the needle pass, and then fire the gun of the needle or fire the needle gun to take the biopsy. Initial systemic prostate biopsy. Prostate cancer can rise away anywhere in the prostate, but it's usually arise in the peripheral zone. Therefore, biopsy are concentrated in the peripheral zone. The summary of the AUA and NCCN recommendation: systemic core obtain at least 12 systemic core that sample the lateral peripheral zone and parasagittal zone. So this is the sample site. It is lateral peripheral zone and parasagittal peripheral zone. Taking more than 12 core biopsy might slightly increase the cancer detection, slightly increase the negative predictive value, and slightly reduce the undergrading, but it increased detection of insignificant cancer. Taking 18 to 21 core biopsy increased cancer detection by less than 4%. So only it's less than 4% by this method. Lesion-directed cores obtain cores from suspicious regions, detection on the prostate imaging or digital rectal examination. Prostate cancer is found in 30% of hypoechoic lesions and 30% of palpable nodules. So this is the prostate cancer. It is hypoechoic 30% and palpable nodule is 30%. Transitional zone sampling is not recommended during the initial systemic biopsies because of its low yield in this setting. Lateral peripheral zone sampling. The lateral peripheral zone sampling improve MBV and cancer detection. Thus, most guidelines recommended sample the lateral peripheral zone. Anterior apical peripheral zone sampling of the anterior apical peripheral zone sampling is redundant. In fact, the AUA guideline states that the clinician should use templates that incorporate adequate sampling of the apex or anterior apex. When the anterior apical peripheral zone is not sampled, 5% of men will have benign pathology despite the presence of the cancer in the anterior apical peripheral zone. I mean, the patients will receive a false benign diagnosis in 5% of cases. 25 to 50% of cancers are present in both the anterior apical peripheral zone and other areas of the prostate. Thus, the biopsy pattern that does not sample the anterior apical peripheral zone will underestimate the amounts of cancer in 25% to 50% of cases. Sampling the anterior apical peripheral zone is especially important in men on surveillance because it is more accurately assessing the extent of cancer. Lateral and anterior apical cores must be obtained to effectively sample the anterior horn of the peripheral zone. The other initial systemic prostate biopsy patterns and 14 systemic core, 4 parasagittal cores, anterior apical, apex and mid, and 3 lateral core, apex, mid, and base on each side. So it is 14 systemic cores. That's 4 parasagittal cores and 3 lateral cores. And this protocol detect more cancer than protocol that do not sample the anterior apical zone and protocol that take viewer core known as MOASA 2020-10. Additional systemic core are obtained in the large prostates. That's more than 50, for example. Cores are obtained from the suspicious area detected on the image or digital rectal examination. So this protocol, 14 systemic is core, 4 parasagittal cores that's we'll use for 14 anterior apical, and apex and mid. Okay, then 3 lateral cores. That's apex, mid, and base. It is 14 systemic. This is the course biopsy. Transrectal biopsy. Transrectal biopsy, ultrasound sagittal plane, as you see, we have anterior horn of peripheral zone, that's the gray here, gray color here. We'll use to take this sample. And then lateral biopsy from the base, mid, and apex. This is known as lateral biopsy and anteroapical biopsy. Anteroapical biopsy. This is the site for taking the prostate. So peripheral zone, gray area presents the whole transitional zone. And also we have fibromusculostroma, central zone. And this is here, this is urethra. Biopsy in sagittal paramedian plane are called parasagittal plane. Anteroapical biopsy. In a sagittal plane, midway between the urethra and the lateral edge of the prostate, insert the biopsy needle so that tip is 1.5 centimeter from the anterior capsule, and then fire the biopsy gun, this core sample all the way to the anterior capsule, is known anterior apical. A large transitional zone may compress the anterior apical peripheral zones, thus the prostate with large transitional zone may require a steeper biopsy angle. This is the anterior apical biopsy of peripheral zones. Transrectal ultrasound in sagittal plane. As you see here, this is the prostate with a large transitional zone, require steeper biopsy or a steeper biopsy angle here. And also you have anterior apical zone. This is paramedial plane. So this is the large prostate, this is a small prostate. Transitional zone biopsy. Transitional zone biopsy sample is not recommended during the initial systemic biopsy because of its low yield in this setting. Transitional zone biopsy may be more useful during repeat biopsy. Prostate cancer can occur anywhere in the transitional zone, but it is not usually located in the distal two-thirds of the transitional zone near to the anterior midline. Therefore, transitional zone biopsy should be concentrated in this region. Insert the biopsy needle through the peripheral zone and into the transitional zone when the needle tip is in the transitional zone, and fire the biopsy gun. With a large transitional zone, insert the needle far enough to adequately sample the anterior transitional zone. Transitional zone biopsy. Transitional zone sample is not recommended during the initial systemic biopsy because of its low yield in these settings. Transitional zone biopsy may be more useful during repeated biopsy. Prostate cancer can occur anywhere in the transitional zone, but is usually located in the distal two-thirds of the transitional zone near to the anterior midline. Therefore, transitional zone biopsy should be concentrated in these regions. Insert the biopsy needle through the peripheral zone into the transitional zone. When the needle tips is in the transitional zone, fire the gun of the biopsy or the needle biopsy gun. With the large transitional zone, insert the needle far enough to the adequate sample of anterior transitional zone. This is transitional zone biopsy, as you see here. So this is trans-ultrasound in the transfer plane, and this is transrectal ultrasound in the sagittal plane. This is sagittal like this, and this is transfer plane like this. Most common location of transitional zone biopsy is black area here. Seminal vesicles biopsy. Men are considered survived chemotherapy after radiation should undergo seminal vesicles biopsy. So after chemotherapy or cryotherapy, it is better to do seminal vesicle biopsy in addition to prostate biopsy because the cancer in the seminal vesicles occur in up to 42% of the men who recur after radiation. The patient recur after radiation or recurrence recur after radiation. So best to assess the seminal vesicle because it might have invasion. The indication for seminal vesicle biopsy in other circumstances is not well defined. So this is the end of today's session. Thank you.